always with the priority of the health and wellness of your patients. And today we have an opportunity to share with all of you this academic program that complements the education programs from Bayer. This is designed to supplement the activities in the first version of this course, but in a more practical way and emphasis in the implementation for decision making. Today, we are with Tamara Navarro Juan, research coordinator of the Health Information Program in McMaster University in Canada, and Professor Iordi from McMaster University. From the first edition of this course, Tamara and Dr. Iordi have been allies in the strategic process, and the second edition of this course in PK has 5 thematic modules. And to bring them to our clinical practice. And the third presented by Dr. Alejandro, who will be presenting his clinical experience and the technical reasons. In the second module by Dr. Tamara Navarro, we will have practical consideration about the use of the WAPS Hemo tool so that we can all become familiar with it and incorporate it in our daily practice. The third module by Dr. Iorio is a practical overview in the management of hemophilia and shows information of trough values. The fourth module by Dr. Querol reviews the impact of individualization of therapy. And finally, the last module by Dr. Ariel Cortez shows a general landscape about health economics, the concept of value, and a study of cost effectiveness of prophylaxis in the Colombian market. On behalf of Bayer, we want to express our gratitude again for your participation tonight and for the great interest that this course has generated to all. I hope it will be useful for all and for the well-being of our patients. So I leave you with Tamara Navarro and her presentation on the WAPS Hemo platform. Thank you very much, Tamara. Comments and questions after the lecture. Thank you, Oscar. This is the third year. We have a great opportunity to show our WAPS Hemo platform and all the tools that we have developed to advance the treatment of hemophilia. Thank you very much.
Buenas noches, bienvenidos a la plataforma Bayer Academy. En esta plataforma podrán encontrar el curso online de farmacocinética aplicada a la hemofilia. Deben poner en su navegador, en lo posible Mozilla o Google Chrome, www.academy.bayer.com y se les va a abrir la página que ven en pantalla. Si es la primera vez que están ingresando, deben hacer un registro y dan clic en registrarse. Les va a aparecer un formulario de registro donde les solicitan unos datos. Es muy importante la casilla código de acceso. Este es un código que deben solicitar al representante de Bayer con quienes ustedes tienen contacto. Es muy importante que acepten la política de privacidad y los términos y condiciones y dan clic en registrarse. Cuando ya tengan su usuario y su contraseña que han creado en el registro, ingresan con ellas. Y ponen su contraseña. Dan clic en entrar. Me recuerda que debo aceptar los términos y condiciones para poder continuar.
It reminds me
Selecciono
that I
la
need
casilla
to accept
y
terms
doy
and
entrar.
conditions.
Van a encontrar la página de inicio donde hay
You will
diferentes
find
cursos
the
virtuales que Bayer
homepage
ofrece en diferentes
with
áreas
the
terapéuticas. En
different
este caso,
online
vamos a
courses offered
seleccionar
by
el curso
Bayer,
de
and in
interés,
this
que es
case,
farmacocinética en hemofilia, dando clic. La página de inicio del curso de farmacocinética tiene una bienvenida con una descripción de en qué consiste el curso, un video de nuestra directora médica Vivian Lee, quien da una introducción al curso, y encuentran además los objetivos generales, los objetivos específicos del curso, la metodología. Este es un curso que cuenta con 6 módulos coordinados por un conferencista nacional o internacional. En cada módulo van a encontrar una presentación magistral, una biblioteca científica con la bibliografía complementaria y un test de conocimiento. La duración total del curso son 25 horas no presenciales. Dentro de los conferencistas invitados en nuestro curso de
among the
farmacocinética tenemos
speakers
al doctor
invited for
Santiago Bonanaz
pharmacokinetics, we
del
have
Hospital
Dr.
La Fe.
Santiago Bonanaz from La Fe Hospital in Valencia, España, Dr. Alfonso Iorio from McMaster University in Canada, the Director of Research of McMaster in Canada, Dr. Felipe Querol from La Fe Hospital in Valencia, España, Dr. Ariel Cortés from Javeriana University in Bogotá, Dr. Alejandro Ospina from Los Cobos Clinic in Bogotá, Dr. Matthew from New Mexico University in the United States, and Dr. Claudia Casas from the Colsubsidio Pediatric Clinic in Bogotá. This is
de Valencia, España, y
the
el Hospital
University
La
of
Fe
Valencia.
de Valencia, España.
Now we are going to enter by clicking here.
Cada uno de los módulos que están en este curso. En la mano derecha van a encontrar una columna con el porcentaje
We are going
de
to find a
progreso de
column with the progress percentage in each of the modules, and we are going to enter module 1 to see how it works. In each module, you will find a module description. You can see display the text of the description, and additionally you will find the knowledge test, and you must select the correct answer and then click next. Additionally, you will find the keynote lecture, the master class for the module, and each of the articles that supplement the information delivered in the talk. It is very important to read each of the papers in order to complete 100% of the module. And if you want to look at another module, you can click next, back, or in the menu go back to module. Additionally, where you see the name, your name, you can display and ask for technical support if you have problems with the platform. If you click, you will see a form where you can make the report, the course to which the report corresponds, and then send. In the same menu with your name, you can edit your profile, and you can edit the information that you first entered, and you can keep track of the courses that have been completed and the percentage of the program. Finally, there is a menu for questions and answers where you can find the answers to the questions that the participants may ask. Once you have completed 100% of the course of all the modules, you'll be able to receive your certificate. Thank you very much for your interest in participating in this course. We hope that it will be useful in clinical practice, and in Bayer we will be there to provide support and the tools. Thank you very much, Tamara, for your presentation. We have some questions in the chat. The first question is the use of the WAPS platform is restricted to Bayer products, or can it be available for other products? Good evening to all. Today we have the pleasure to have Ms. Navarro from McMaster University. Thank you very much, Tamara, for your presentation. My name is Tamara Navarro. I'm the coordinator of the project. I would like to thank Bayer Colombia for this opportunity to participate in this presentation. I will go over information about the MyWAPS tool. It's a new app available at the WAPS website. And during this presentation, we will look at the usefulness of this application, and then we will review how to install it, and we will show at the end a short video of the app in action. MyWAPS is an application that allows a patient to see estimates of their factor level at any time and in real time. The patient has available offline and online the regimen, online or offline, and can stream information on infusions through the app directly to his page, and can use MyWAPS to control hemophilia. Patients can see factor levels, including future estimated levels, receive notices when the time comes for the next infusion, and receive notices when the levels of the factors drop to a very low level. There are 4 steps to start using MyWAPS. The physician must join WAPS Hemo, must enter infusions in the patient's profile, must choose the clinical calculator to prepare the therapeutic regimen, and must apply the MyWAPS application. To use the application, they first need to join the WAPSIMO platform. If you have not joined the platform, go to the WAPSIMO site.org and register your center through the registration window. Then our team will send you a reply with more information about the process. And then you will be able to create your user credential, read and sign the user agreement. In the site, you need to create a new patient register or add a pharmaceutical study for an existing patient. In this case, we have a patient here. And we are going to work with this record. And just write the dose that has been infused and the medications. You don't need a pharmacological washout period, and you don't need trial doses. all you have to do is take 2 or 3 samples after 1 or more infusions administered as part of the usual prophylactic regimen in less than 24 hours. You will have in your inbox, in your email, a link to the pharmaceutical results. Comments and suggestions, personalized comments and suggestions made by WAPSIMO experts will help you interpret the results and will help you solve potential incidents. The interactive graph and the report that you will be able to print will help you educate your patients. Then, using the calculator, you will be able to determine in real time what is the best option, the best treatment option for each of your patients. Using the clinical calculator, you will be able to set the treatment suggested for the patient. Select 2 out of the following 3 parameters or settings: dose, frequency, and minimum concentration objective or target. And here we're going to give you an example, writing the dose and the interval between infusions. We are going to select 1 and 2 here and click calculate, and this will give you the treatment estimate. You can store treatment recommendations in the patient's own record and then print the document to give it to the patient. Now you're ready to activate My WAPS app. Go back to the patient's page. And on this page, go to the treatment plan window and select the plan suggested for the patient. Then go to app settings and introduce the patient's email address. You should click here for your disclaimer of having prepared this treatment. Now the patient will receive an email detailing information about the MyWAPS application. The patient will have to click on the link in the page in order to activate the account and generate a password. The document that is displayed gives information about privacy policy and conditions for use of the app. The patient must accept and save. And then the patient should go to the App Store or to Google Play to download the app. Once the infusions are recorded, they will appear in the patient's data sheet. For more information, visit our MyWAPS site. This short video shows you how the app works in the patient's phones. This is a brief presentation to show how the patients can use MyWAPS. In the home page of the app, the patient will be able information about their levels, a treatment plan, a calendar showing past and future infusions, an estimator to show the levels that they will be at in a close date, and a screen to adjust. To record an infusion, the patient must go to levels, press the blue button, and here they'll be able to enter their infusion. They must verify the dose, date, and time when the infusion was administered, and then save this information. This will show the estimated factor level in the future. And so here we see when different levels are reached with the infusion information that has been recorded. And the patient also has information about the treatment plan, including the medication and dose, the next scheduled infusion, and also notes about past infusions. This information is also available in a calendar form using past infusions and the future infusions. This tool also has an estimator, and the patient will be able to see the different levels in the future and when the new infusion is coming up. The patient can make adjustments, can change colors, and can initiate notices, change language, and can also see the privacy policy and the terms of use. In this presentation, we have given you an overview of how MyWAPS app is used to help patients control their hemophilia. The app allows the patient to write their infusions, keep a record of their infusions, participate in their own treatment, and forecast future factor levels. If you want more information about this app, just visit our site online. You can find us on mywaps.org. Thank you for your attention, and if you have any questions, please do not hesitate to contact us through the WAPS Hemo website. Thank you, Tamara, for your excellent presentation. We have some questions in the chat which we'd like to ask you. The first question is whether the use of the MyWAPS platform is restricted to Bayer products, or is it open to any other product, and is the platform available in Spanish? Yes, we have several products. The platform is not for use exclusively for Bayer products, so you will find many of the products available in the market if we have data about them and if we have conducted studies about them. The platform is also translated into many languages, including Spanish. There are some links that we still have to translate, but yes, most of it is available in Spanish. Another question, how does MyWAPS manage data confidentiality? How do you guarantee that the information remains confidential between the patient and the treating physician? Patient list is controlled by the center, by the physician. They don't have to give us patient names or information. We just get a number. And internally, we give the patient a code, and that is how we follow the patient internally. So these lists are controlled by the physicians, by the centers themselves. We have no control over them in that way. Somebody else is asking, could you tell us of an experience about centers that have already implemented the use of MyWAPS and how they implemented the tool with their patients. I think that in Colombia there are 7 centers already that have registered with us. Colombia was among the first to join the project. So they've been with us for almost 4 years, and they continue to use the platform because they find it to be a valid tool for the treatment of hemophilia. And finally, we're being asked if you have any feedback that the patients may have given about the use of the tool. In the website, you can find patient comments. Yes, it is a tool that they had been expecting, and they were very interested in its development, and they're happy to see that it is available on the website. Tamara, again, thank you very much. We will wait for other centers to implement the MyWAPS tool, which we believe is going to be very useful for the treatment of their disease. So again, thank you very much for participating in this event. Now I have the pleasure of introducing Dr. Iorio. Dr. Iorio, as I mentioned in the introduction, is professor of the medical department in McMaster University in Hamilton, Canada. And for us, it is a pleasure to have him with us tonight.
Your presentation. Thank you so much.
Thank you very much, Oscar, and good evening, everyone. I'm very sorry I can't deliver this presentation in Spanish. I can understand Spanish, being Italian mother tongue, but I would not feel comfortable presenting in Spanish. Let me see if I can share my screen. Okay. And let me also thank Bayer for the very welcome invite to discuss with you this data. And please feel free to stop me if something goes wrong with the presentation, you can't see the slides, or my voice does not come through clear. I will focus on the learning we have done through WAPS and through other studies about switching between clotting factor products. You know about WAPS, you know how we have been more and more making use of pharmacokinetics to identify the optimal treatment for our patient. And as Tamara was reminding you in the discussion, we have a lot of usage in Colombia. So thank you very much for using our platform and so providing data that we can use for improving care. One of the critical moments in treating a patient is decision making around switching products. When the new products come available on the market, we tend to offer it to our patient and to switch them from one to another if we think that the patient will be better off on the new product. Unfortunately, I forgot to put up my disclosure. Oscar gave a very kind introduction of me, and I just want to thank once more Bayer for providing a support to our research program, to the Endo chair in epidemiology of congenital bleeding disorders, and supporting many studies. I was saying that there's not a lot in the literature around how to manage switching. The guideline of the ISTH suggests to do a PK study, so do the guidelines in UK and the recent WFH guidelines. they not only recommend pharmacokinetics tailored prophylaxis as the standard of care now, but they also recommend to do a PK soon after switching to make sure that the patient is still treating optimally. But if you think of any suggestion about identifying before switching which product can be better for any specific patient, there's very little out there. We have done a systematic review. Jackie Yu, a PhD student at the University of Waterloo, our partner university for WOPS, did a systematic review searching for studies trying to find out how to best switch patient with some prediction of what their half-life will be. But really there's nothing out there. Most of these studies around switching were done either to assess the inhibitor risk or to compare two molecules. So a few patients studies before and after switching, but the goal was comparing the two different concentrates, not finding ways of switching patient in an effective way. We have done some research work on WOPS data, trying to see if there was any characteristics of patient PK profile that were useful to predict their half-life on a new concentrate. So the objective of these studies were essentially to explore methods to predict the individual PK profile on a future factor VIII products by using the individual PK profile on the prior product. If you think of your own practice, those of you who do population PK studies in your patient, when you have a patient on a concentrate, you know their profile and you can optimize their treatment. Now, if you plan to switch them to a new product, you don't know what the PK will be on the new product. And what we have tried to do with these studies is to see if knowing the PK on one product can be used to predict the PK on the products we are switching to. Now, there are three methods that you can think adopting, and we have compared them. We have not even considered just assuming that a patient would have the half-life that is on the leaflet. You know, if you take a standard factor VIII concentrate, you may find that some have an average half-life of 12 hours, some other 14, some 10. But that's really the average. We all know that not many patients will have that average. Some will have shorter half-life, some will have longer half-life. And we know that some of the determinants are, for example, age. We know that kids have shorter half-life and adults have longer half-life. Blood group, patient with blood group O, as I show you later on also in our own data, have shorter half-life. Patient of blood group A, B, or AB have longer half-life. And then weight, and then body mass index. So there are characteristics that make the half-life of the patient already different one patient to another. So the gray line here represents just using the average in the population. The blue means using the covariates of the individuals. We know that the blood group is such, the weight, the age, the height, and so on. The most precise way is when we have also some measurement. When we have the measurement, we know how much that patient is far apart from the average in the population. And this is the first method that we have used. So we consider how much one patient is below or above the average on the factor VIII he is on, and we use that value. So say it's here. Here is the average. This patient is a bit more on the long side of half-life. So he has half-life or a PK, a clearance, AUC, whatever you want, slightly larger, longer than the average. So we measure where he is on this distribution for one patient, and we take the same point on the distribution for the second product. And we can say, you know, your half-life was 10 hours here, which was a little larger than average. And here will be, say, 13, which is little larger than the 11 for the average. So this first approach uses the positioning of the patient on the derivation population and the same position in the distribution of PK for the new concentrate. The third method uses the same information, but instead than just moving from one distribution to another, does this study across a population of patients, say 10, 12, 15, how many you may have available, and then for each of those points goes to correlate the points in the other distribution and tries to find a relationship. So maybe you are not exactly in that very point, but you are close to it. So this is a sort of like method 2, but then averaged across a few patients to find out a linear relationship. Now, to make a long story short, what happened is that if you use the information on the leaflet, just the average, your error is about 50%. That patient can do better, can do worse, but you cannot really predict what his half-life, his PK will be, abandoning all what you know about the patient and just looking at the leaflet. If you use the typical covariate, so you take just the age, weight, body mass index, blood group, and so on, you still have a residual error of about 25%, but with a huge variability. You can be 5 to 75% above or below the truth. If you use the previous PK-based method, the one that moves the position in the two curves, you reduce this variability from 25 to 15, and more than that, the spread goes down to 3 to 42. If you use the regression line, where you study a population switching from product A to product B, and then you do a regression through their value before and after the switch, your residual error now is 10%. You know, you can still, you will still be more precise once you have done a study, but even before the study, your error is 3 times less than by using the typical covariate model, and 5 times less than just using the leaflet information. And the variability is less than 30% at maximum. So we think that this method is valid, and in fact, we are working on making this prediction capacity available for a few products. And the one we have enough data to do to apply these prediction models are GV, the long-acting for the long-acting by Bayer, and Eloctate, the long-acting currently by Sanofi. To give you a graphical representation, this is a busy plot, but I'll give you the basic idea. If we were able to predict perfectly, say, the half-life of one product based on the half-life of the other, we would be seeing all the points on the diagonal. Okay? Now, the comparison of method 1, just the covariate, you don't even see it, but it's this blue line here. So there's really no relationship. We are very far from the diagonal, and your prediction can be all over the place. If you move to the method that moves one distribution to the other, you are in the orange area. So the line now start moving from the just guess toward the diagonal, but we are still very far from it. When you move to method 3, the one that is based on a population of patients switching, you see that we are not perfect, we are not on the diagonal, but we are much closer to where we should be. Our prediction is much better. If the patient will have a short half-life or a long half-life, we have a good chance of predicting. This is another study where we are switching patient from Advate to Novoate, and is exactly the same. Using just the patient characteristics, we are very flat. Using the method 2 and 3, you see that the regression line, they get closer to the diagonal. And in this case, again, the purple one, method number 3, is the most efficient. So essentially, one of the benefits of collecting data through a system like WOPS is that respecting the privacy with anonymized data, we can use this data to generate ideas, test them, and hopefully come up with a solution that would be more useful for clinical practice. Now, I told you that this method may not be available for all products, and the reason is that you need data from switching to build those methods and make them available in WOPS. And I want to show you data that we are using these days. The programming of this module in WOPS is still underway, but very advanced. Using state-of-the-art studies. I'm citing here a paper we published with a large group of hemophilia PK experts on RPTH, research and practice in thrombosis and hemostasis, a couple of years ago, where we demonstrate that to be able to compare two different concentrates, the best design is the crossover study, where you treat the same patient before with one concentrate and later on with the others. And the reason is that if you have the same patient population and the same centralized laboratory assay, you really are comparing only the two concentrate, and all the rest of the variability is minimized by using the same population, the same lab test. And we have a lot of such cases in WOPS. We have about 700 patients, of which 400 adults and 274 children, having at least one study on one concentrate and one on another. And just to show you, on this patient, we see the known difference between standard and extended half-life on average. But the beauty of this data set is that for each one of those patients, we have a pre on one concentrate and a post on a different concentrate. So we can use this data to build predictive model. Not only, but we have even research-based data that we can use to build these models. And I'd like to present you very quickly two studies done by observing patients switching, in one case from Eloctate to GV, and in the other case from Adynovate to GV. And I had the pleasure of being involved in the analysis and publication of both studies. One is already out in the Annals of Hematology last year, and this one, where the first author is Alex Solms, the PK group at Bayer, accepted on the Annals of Hematology and will be out hopefully in no more than a month. The third study I had the pleasure of doing with my colleague Manuel Carqueo in Toronto, published in Thrombosis and Hemostasis last year, compares Adynovate versus Eloctate. So the two studies switching from Eloctate or Adynovate to GV were head-to-head randomized studies. So in one case, the patient were randomized, 18 patients, randomized to have first a dose of GV, 60 units per kg, or a dose of Eloctate, again 60 units per kg, do a PK study, and then after 6-day washout, crossover. And those who had GV will now have Eloctate, and those who had Eloctate will now have GV. The same was the second study, where again 18 patients, 9 started with GV, this time 50 units per kg. The other started with Adynovate, and then they crossed over and went to the other concentrate, 50 units per kg in both cases. Now, the result in a nutshell, if you want detail, I'm afraid you will need to go and read the papers. You can ask me or Bayer if you can't get them at your site. They are free access, so you should be able to get them. They are easy to read and very interesting, but then in a nutshell, the result is shown in these two graphs. Here, what you see depicted in green is Elocta, and what you see depicted in red is GV. And you see that at any given point in time, the level of factor 8, this is factor 8 level, this is time, the level of factor 8 on average are higher for GV compared to Elocta. Now you see that there is some overlap. So there are patients doing worse and patients doing better, but on average, GV gives a higher level at any point in time compared to Eloctate. And you see that the same is true when the comparison is with Adynovate. Again, time, concentration, 9 patients receiving both concentrate. If you plot their level on Adynovate versus their level on GV, GV was above at every single point in time. But again, lot of variability. You can have patient doing worse or patient doing better on both concentrates. Which is even more clear on this plot. I'm showing in the AUC, and leave alone this patient. This patient here was a patient with natural antibodies against PEG, and so on the first administration of PEG, he didn't have a good recovery at all, and the PK study was essentially impossible to do. This patient is doing well, by the way, and the natural antibody against PEG are naturally eliminated, so the patient is now treated with GV, but it was essentially non-valuable for the PK study. But you see that even if more patients do better on GV, there are some that do the same, and there are some that really have a slight decrease. This patient here goes slightly worse. This one does much better, and there are some that stays more or less the same. So going back to what I was telling you before, would be important if we were able to predict by looking at these values here, who will be up and who will be going down or staying the same. And you see that, there are all behaviors in there. If you look at this one, this is Adynovate to GV, most patients, they go up. The average go up like that. But there are few patients, in this case 2 patients, that actually were better off on Adynovate. This is where we would enjoy and benefit from doing POP-PK study. And I'd like to point you to the full transparency of Bayer. Bayer, of course, sponsored this study, but when we did the analysis, they were very open to tell, yes, on average, our product is better. There are a few patients where the balance may be in favor of a competitor. You don't usually find so much openness, and I think we should applaud to Bayer for their transparency. But the bottom line out of these studies was that you gain about 12 hours on an infusion cycle by using GV, no matter if you are considering time to 10%, 5, 3, or 1. The product is staying around for half a day more. And if you compare with Adynovate, in this case, the 2 curves are slightly different. So Adynovate is a bit faster in the tail of the curve to disappear. So the difference is 7 hours if you look at 10%, but if you look at 1%, the difference is now 16 hours. This is the effect of the shape of the curve for both concentrate. Now, my last study that I'd like you to review with me is a natural switch that occurred in Canada for a tendering process. We had the loctate, and then, in Canada, we have centralized tendering processes and procurement processes, and at some point, we did not have any more Eloctate available, and we had Adynovate. So many patients switched from one to the other. And at Sick Kids in Toronto, they switched 25 boys from eloctate to adynovate. And for all of them, a PK was done, 5 points, a pre-dose, and then 3, 1 day, 2 days, 3 days before and after, before and after the switch. And we did centrally in Kingston, Dr. Lillikrap, measurement of factor 8 with 1 stage and chromogenic. And the PK were done with WOPS. Again, the two curves are completely overlapping. There's no difference between eloctate and adynovate. They are essentially identical, but you see how much dispersion in the values. In white, you see eloctate, and the circles are eloctate, the lozenges are adynovate, and you see that there's a large interpatient variability, which is what we'd like to be able to predict. If you look at time to concentration, again, there was no difference, 68, 65, for getting at 5%, 70, 80 hours getting at 3, and 110 approximately hours to get to 1%. And again, there were a few patients, the one that I'm pointing you at here, that they were doing better after switching to adynovate. So these ones, they improved. Every one of them had a better half-life, but there were as many that had a worse half-life going from eloctate to adynovate. So on average, the two products are identical, but for each individual patient, they can be better off on one or the other. I want you to put 1 minute of attention considering all these 3 studies together. From the GV to eloctate comparison, we learned that GV had a longer half-life and a more favorable PK than eloctate. And from the GV to adynovate, we found that this one, the GV, was better than adynovate. By comparing eloctate and adynovate, we discovered they were identical, which fits in the picture. If GV is better than one and better than the other, they have to be the same. They have to be identical. So I would think that these 3 studies together give a very good idea of how long-lasting this product is, and give us a lot of data that we can use for optimize our prediction models that we will make available in WAP soon, to let you discuss with one of your patients that you have profiled already on a concentrate how he would improve, if he does improve. Because if he's one of those that do not improve, well, maybe it's not worth switching, or it's not a perfect prediction, so you may still switch, but your expectation is, unless surprises, I might not be doing better. While for others, it will be very valuable to switch, because we know that they will have a more favorable PK. And this was my last slide, and I thank you for your attention.
Thank you so
Muchas
much,
gracias,
Dr.
doctor
Iorio. It
Iorio.
was a
Realmente
very
fue
nice
una excelente
presentation. Gracias,
presentación.
Dr. Iorio.
Thank you,
Excelente
Dr. Iorio. It was an
presentación.
excellent
Tenemos
presentation. We have a
algunas
few
preguntas.
questions.
We have some questions. La primera tiene que ver con algunos mitos asociados con la transición de terapias en pacientes previamente tratados con hemofilia A. Dr. Iorio, what does the evidence tell us about some myths around switching therapies in previously treatment patients in hemophilia A?
Is the question around inhibitor risk in this patient?
Yeah.
So, thank you. There is no evidence that switching in previously treated patient is associated with the risk of inhibitors. It has been discussed in the community for long. There was a suspicion around the time that Rifacto hit the market. It was B-domain deleted, was very new, and there were a few studies suggesting that even in PTPs, there was an increased rate of inhibitors. Those data have been reanalyzed over and over, many more have been accrued, and even in that case, there is no measurable increase in the risk of inhibitors. So I would say quite frankly that there are now thousands of patients studied across switch and there is no increased risk of inhibitors now.
Okay, thank you. Tenemos otra pregunta. Why a hematologist should not use the one-size-fits-all dosing method to prescribe its hemophilia patients?
Right. You know, if you have no access to a lab, if you can't measure factor VIII, you have no other option than guessing. And you start with a standard dose, maybe the one that was used in a study. You observe the patient. If the patient does not bleed, you are happy. If the patient bleed, you go up with a dose. You know, I understand that there are settings where you may not have access to lab test. But if you have access to lab test, and every one of us nowadays, no matter in which country you are, have access to internet, there is no really any more reason not to do two measurement of factor VIII, day 1, day 2, or day 2, day 3, put them into a software like WOPS and get a PK. You don't need anything more than that. And really, if you have a lab, you can do a PK very easily. And this is why the UK guideline and the WFH guideline, they now recommend as standard of care doing the PK, because we have demonstrated through the over 15,000 PK we did in WOPS that it does really matter. And there are patients that needs 20 units per kg every 4 days of a standard half-life, and others that need 60 every other day, or they will be going below 1, 2, 3, whatever target you select, depend on the level of activity of your patient, their bleeding history, number of joint score. But yes, not doing tailored PK has no more any excuse in 2020 if you have a lab.
Okay, thank you. Tenemos otra pregunta respecto al primer estudio de extrapolación de la farmacocinética de un producto a otro. Dr. Iorio, despite GD was not included in your study about extrapolating PK from one product to another, could we infer that the results may be similar? For example, thinking in a switch from cogenate or any other standard half-life factor 8?
So we could infer, but we would take some risk in doing so. That's the reason why we insisted getting this data from the study I presented you, plus data for patients switching from covalently and cogenate to GV, and we are using those data to check if the model predict well for the switch cogenate covalently to GV and adenovate L-octate to GV. So we can presume, but we are working this day on having specific model for switching to GV.
Okay, thank you. Tenemos otra pregunta respecto a la sugerencia de algún algoritmo para guiar la transición de productos de estándar, de vida media estándar a vida media extendida. Dr. Iorio, could you suggest any sort of algorithm to guide the switching from a standard half-life factor to extended half-life factor?
So in waiting for algorithm that can help you and software that can help you, the approach I suggest is to switch the patient keeping the same dose. So whatever he is on, say he's on 40 units every third day of a standard half-life, my suggestion is to take the same dose and the same frequency of the long-acting, so that you are sure that he will be approximately same or maybe better. Do 5 infusion and then do a PK study. I suggest not doing the PK study on the first infusion because there will be a bit of the old, a bit of the new, and there is not yet steady state. If the patient lives close by or has a chance coming back, I would just switch him same dose, make sure that he gets 5 infusions, that he does not bleed, and then have the patient back taking 1 point or 2 points, even better, and then do a PK. At that point, you will know what the half-life is on the new product, and you can use swaps to optimize treatment, and then maybe you can say, you know, you stay like that, but your trough is higher, or we can gain 1 day, gain 2 days, or whatever you will be will be possible do for each individual patient. So that would be my suggestion for an empirical approach to switching.
Okay. Okay, Dr. Iorio, thank you so much. We don't have any more questions. Le agradecemos mucho a todos por su participación. Les pedimos excusas por algunos inconvenientes técnicos que tuvimos al inicio. Las presentaciones van a estar grabadas, así que las podemos compartir posteriormente con ustedes. Y de verdad, a todos ustedes, muchas gracias. Doctor Iorio, Tamara, muchas gracias por su participación y esperamos que nos acompañen en una próxima oportunidad. Muchas gracias para todos y que pasen una feliz noche.
Encantado.
Thank you. Bye.
Gracias. Adiós.
Adiós. Gracias.